All right, we are going to go ahead and get started. Thank you guys. We're going to wait. We're going to have a couple people trickling in who are stuck in traffic. If you haven't cast your vote yet for the vice chair, the very important shoebox is over there, where you will write your vote and put it in the box. We're going to count them a little later today, and we'll have our winner by the end of the meeting. Okay? First things first, the minutes from June 14th have been distributed to you via email. Are there any corrections? I did not receive any via email. Are there any corrections you'd like to bring up at this time? Okay, if no corrections, the minutes are approved as distributed. And our next item on the agenda is Phyllis, who's going to share a report out from the Community Engagement Subcommittee.
Okay. We met and started out with essentially defining what we're supposed to be doing. So we could figure that out. So we developed a purpose, which was very straightforward, and that's essentially to develop a plan. But we realized that that didn't have any meaning for us. That what we wanted to know was, why were we developing a plan, an engagement plan? And I mean, on the most obvious level, it's the PC thing to do. You involve the community in whatever it is you're doing. But that what really wasn't good enough for us. And we had a discussion that I honestly wish all of you could have been at, in that we really talked about, why would you engage a community in something like this? What was the purpose really of doing that? And what we came up with was to promote coordination, collaboration, and hopefully sustainability, because we would share a vision and share priorities. We also thought it would foster a community voice and a balance of power among all the segments. And that's what we really then got into, was the whole picture of Lakewood, and not just little pieces here and there that pop into your mind, but instead, who really was out there. And that mattered to us a lot. We thought that we were engaging the community so that we could remain effective, and that the board after us could be effective by getting a lot of feedback. And finally, we thought that we could enhance trust, that was a very practical way to do it, through accurate and timely communications, through transparency and accountability. And that would be our job, and then that would be the job of the board behind us. And that was our best thinking on why on earth we might be doing this. And at that point, we felt really good about the fact that we were doing it, because it really seemed like the right thing to do. We then looked at that list, which, remember the list, Randy put it together. It was from the questions everybody answered. Well, it was all these wonderful people and wonderful organizations, but it didn't really speak to what we wanted to know, which is, what were they representing? And so we went back and broke those names and organizations out, and I think you all have this before you, into an interview list. But we did it by population or interest groups as compared to people. And what we thought that that would accomplish was, we could look at this list and see, were we actually getting most of the important segments? And so that's how we decided to divvy everything up. It then became impossible, though, to prioritize it, because how can you prioritize it if everybody's supposed to have a voice? So that was a little stumbling block, but But it isn't that much of a problem because there's only, I think, 14 or something major categories, so it's just not that big of a deal. And I know, Randy, you said you were going to be doing quite a few of these, and there's 4 of us, and Brittany O'Connor also volunteered to interview. So we're pretty well set in terms of people that could interview. But we really need your help with this list, big time, because we're missing. I mean, there's organization, like a population group or an interest group that you know perfectly well matters, but is there anybody you can think of that actually represents that population? You know, who could we talk to? And we intend to also ask that in all of our interviews, and hopefully at some point get this list completely filled out. Also, if you have another population or issue group, let me know. I think we've pretty much covered the bases, but you may find something important that we've omitted. And so what I would ask you is over the next several days, please take a look at this and help us fill in those blanks. And then email me, and we can get a more complete list put together. But we feel, even though there's a lot of blanks, we feel pretty good about it right now, because it really is beginning to be a representative list. Finally, we put together a list of the questions that we thought ought to be asked in the interviews. And we tried not to ask a lot of questions, but you know, to ask what we thought we really needed to know in order to move on, or whenever we did, to the communications and to the planning phases. So these are the questions that we came up with. There's 6 questions, but then some probes. And we didn't really talk about how long the interviews would be. I assume half an hour, 45 minutes maybe at the most. I guess it would depend on how many people there are too, because a lot of these lend themselves to panels rather than individual interviews, I think. And that's where we stand. So we completed our assignments as we defined it. And if there were other ones, we just crossed them off the list. And that's all I have to report. Committee, do you have anything you want to add? Dan or Mike or Martha, Chief Speaker? If you ever need an editor, go to Martha. Martha is the world's best editor on the face of this earth. You are.
Do you have a due date? Like if people want to send you suggestions, do you have a due date in mind?
Maybe by the 5th or the 6th of July. 6th of July, let's say. We already have enough to get started a little bit, maybe, but. Oh yeah, how do we send them to me? I guess me and only me, and then I can send them out. You know, I can keep a running list. The only thing I'd ask of you is if you type it in on this, do it in a different color ink, or I might not notice what you've added in. And that's all. Do you have any questions?
Question, Phyllis, just looking at the interviews questions. In number 1, you use the term wellness, and then in number 2, you talk about greatest health challenges. Is that intentional that those are different terms?
No. So you think make it wellness challenges?
I think so.
Fine. Look out, Martha. She's creeping up on you as an editor. Anything else you want to comment on? Suggestions for change?
I had one question in the very first paragraph, second line where it says, explain what the foundation is. I wondered if that should be explain what the foundation is envisioned to be, because we don't know what the foundation is yet, in my estimation. That's what we're trying to figure out, so. You see what I mean?
Yeah, all right.
Does that make sense?
Mm-hmm.
Okay.
Including the name.
Yeah, I thought about that in using that here. We don't even know if
But
it's the
not-
name.
But that's not
Okay.
determined to be the name.
Anything else I can?
Phyllis, can I add? Maybe I'm just a little sensitive to this, but can we change people of color to like minority ethnicity or something else? Is people of color the current term?
Mm-hmm.
It is.
It is, okay.
Actually, a multicultural community might be better, because it's inclusive of everybody.
But we don't want to include everybody on this, in this particular category. We want to include every ethnicity and race.
I think maybe if we had an organization in there too, it might fill it out a little better.
You think what?
Maybe if we had an organization listed there, it might fill it out better.
I agree. So what am I calling it then? Yeah, an individual, we're looking for individuals on this list also, by the way. So not just organizations. I'm sorry if I misspoke. The other thing I was thinking of is that we're certainly not going to start the interviews before you give these comments, and we are going to ask that question when we go out and talk to people. So maybe that would have to be a question we're really going to have to press on and be more specific. Do you know anybody we could go who you would consider to be representative of whatever?
I would just recommend that maybe we change from churches to faith communities, because
You are correct. That was the Catholic in me. It just took over.
Question. We talked about the last interview we had with the Department of Human Services. I think the last question that Aaron posed were where are the gaps? And that kind of a question is not here. This is really about the task force versus finding information out about that organization and where they think gaps are. So the line of questioning is a little different here. If we're talking to organizations, are we also trying to find out where gaps are versus what they think of the task force?
I have look at question 2. In your opinion,
Sorry, I
what are
missed
the
it.
greatest wellness challenges?
I'm sorry,
And
I
are
missed
any
it
of those
when I was
going
reading.
unmet?
Okay, sorry about that.
I guess I like the phrasing though.
Are you saying use that in every situation? All right, then what do I do with that question that says, how do you define, what does wellness mean to you? Can I use that there? Not really, well, never mind. Yes, ma'am. I thought about that. I didn't know whether to make it in early childhood or make a youth, could I make it early childhood? science in early childhood?
Can you clarify, again, I guess, the style and how you might be approaching these, and if you haven't decided that yet, because I heard you say something about people doing specific interviews, and then I heard you say some of the questions being produced as more of a panel setting.
No, I meant, well, if I said that, I apologize. I meant some of these on the list are conducive to panel settings.
Okay, thank you. And then also, and again, you might not be here yet, but do you have an estimated time frame in which you may start?
Well, I wanted to talk to Randy about that. I need to know how many he plans to do and when he plans to start. And then we can figure it in from there.
Excuse me, I think that it's just more of how Randy prefers that we do the interview structure, whether it's on each of us on an individual basis, or if it's the panel all together plus Randy, or the holistic group for each subset here.
I think by panel I meant the people we were interviewing, not all of us.
Right.
Oh, okay.
I will make some recommendations based on what's here as to what I think could work. And for some of these, I think a focus group would be appropriate. In other cases, it's really going to be important to do one-on-one interviews, so I'd like to work with the subcommittee just to sort of further distill how we go about that and make the selections.
Are you available by any chance on Tuesday night? Because the 5th, is it Wednesday? Because we're having a meeting and we could just sit down and plot all that out.
That's next week?
Mm-hmm.
I can check.
Okay. No, I don't. Behavior health, that's what you're interested in.
You just wanted to combine it into one category with recovery resources as one of the people. Murtis Taylor also.
So you want to do behavioral health, addiction, and recovery?
If you say,
Yeah,
if you
say behavioral health, it kind of
includes all
encompasses
those.
addiction and recovery.
Wouldn't that then include people with disabilities, potentially?
Not necessarily. It's usually referring to mental disabilities, schizophrenia, bipolar disorder, as well as addiction. So for
That's what I meant.
physical disabilities, that would be a separate category, and as it's generally understood.
Anything else?
Really? Oh, but my voice is so annoying, and then I have to hear it. Okay, sorry. Do the groups that we interview have to be, he knows what I'm talking about. Do the groups that we interview have to be in Lakewood, or could they be organizations that touch in Lakewood? Like, for example, people of color or diverse races and ethnicities. I think about the Northeast Ohio Black Health Coalition, which is in Warrensville Heights, but has a pretty broad scope from Cuyahoga County all the way through Lorain County. Do they have to be in Lakewood, or can it be kind of geographically broader in terms of getting some insight?
I think that's up to everybody. My first choice would be that it be in Lakewood. But if we can't find anybody in Lakewood, then I think we move on to wherever we can find somebody. But ideally,
Yeah, I would think if they service or do business in Lakewood, then I would think that would be good enough for me.
right.
Or with Lakewood residents specifically.
Yes, yeah.
Well, we have businesses as a category here too, and we don't expect business owners necessarily to live in Lakewood. Just by following the same lines. I'm just thinking to correct myself. I would appreciate all your comments on the interview list by the end of the day on Tuesday, and then that would be the time to put that final list together for next week.
That's July 4th.
Tuesday?
Yeah.
Maybe do it by Monday.
Yeah, by Monday.
Phyllis, may I make one recommendation to that process? Perhaps so that folks don't feel constrained in terms of geography or other ways, maybe we can just feel free to brainstorm, send any ideas that we have your way, and part of our conversation in the subcommittee could be kind of calling that list. So if people know of, you know, organizations that represent people of color that are not necessarily in Lakewood, but are in a neighboring community, they could send that to you, and then our task as a committee will be, well, maybe that's out of the geographic scope or whatever, we can kind of narrow it. But I would hate for people to feel constrained in sending you ideas, so maybe just send any ideas that you have.
Well, they did that originally, too,
Yeah.
and we told that list, just because we couldn't, like it would say, somebody familiar with low-income issues. Well, we put low-income as a whole category. I don't remember if it's low-income, but just giving that as an example. But somebody familiar with low-income issues wasn't first. So it only made this list if it was somebody who could actually add it on.
So one example of that would be like the Legal Aid Society. I think they do a lot of medical legal partnerships. They do a lot related to health, but they're not necessarily based in Lakewood, but I'm sure some of their clients in Lakewood. So I guess I'm suggesting that I would hate to feel constrained in sending you that recommendation, which I think is a really good recommendation if I do say so myself, because I feel some sort of arbitrary constraint. So I guess I just am offering this to you as an option, Phyllis, that maybe we just send you any ideas that we have, and then, you know, as a small group, we can narrow them.
Because, I mean, it seems to me with legal aid, that's a perfect example because they're doing something in Lakewood that really matters. And so there's not a whole heck of a lot of difference between actually state. Okay, good. Now let's work together.
At 5:30, I thought.
You had 5:30? 5:30 to 7. Okay, anything else? Well, thanks to the committee. I mean, the committee, this is their brand new, very good job. Comments by July 3rd.
Did we hear from George or Brittany?
No.
Okay. Did everyone that's in this room vote on the vice chair? Once. Didn't stuff in any extras. You didn't replace your name. All right. We are going to consider the polls closed. Randy, we can get started with the speakers to respect their time, and then we will announce later. All right, so our first speaker that we have with us tonight is Kirsten Krashen from the Center for Health Affairs. And she is the Director of Community Outreach. One of her many roles is helping hospitals conduct their community health needs assessments, and she's going to share some information about that with us this evening.
Thank you so much.
And so it'll be 20 minutes of Kirsten talking. I can give you a little flag when we have about 5 minutes left, and then it'll be open for questions. All right?
Great. Starting my timer. Well, thank you all so much. I was absolutely thrilled when Judy reached out to me to ask if I would be willing to collaborate with Martha on this presentation to share with you some health needs information that we have. So I'm going to start by sharing a little bit about my organization in case some of you are unfamiliar. I know Ben, Dan, Judy, I know a lot of people in the room are relatively familiar, but we're a hospital association that serves Northeast Ohio hospitals, so we have about 35 hospitals in our membership. We cover a 6-county region that includes Ashtabula, Cuyahoga, Cuyahoga, Lake, Lorain, and Medina counties. And you can see all of the hospitals listed here. Some of them are from bigger systems like Cleveland Clinic, University Hospitals, Metro, but we also have some smaller hospitals within our membership as well. And just so you can get a bit of a sense for what we do at the Center for Health Affairs, we've actually been around for 101 years. We just celebrated our centennial last year, which was exciting. And we have a business affiliate, Champs Healthcare, which I'm not going to spend any time talking about, but sometimes people aren't aware that that's actually falls within our umbrella. And then I work on the association side of the organizations where we do a lot of member services, and you can see some of them listed under the blue circle. So we do a lot of work on workforce development, trying to ensure that we're going to have sufficient nurses in the future. We also work with our members on finance and reimbursement issues. We do a lot of work in terms of emergency preparedness, helping to coordinate efforts to make sure that the hospitals in the region is prepared in the event of any type of an emergency. And then I spend my time doing a lot of work in community outreach as well as some work in policy and advocacy. So obviously it's been very busy with the state budget and then all of the things happening at the federal level. And then under the orange circle, you can see some of the things we do. All of the work that we're doing in terms of addressing health needs really falls from what we know out of the community health needs assessments, which I'm going to spend the bulk of my time talking about. But you can see some of the issues which we're starting to address listed here: childhood asthma, infant mortality, which is a huge issue for Cuyahoga County and some of the other counties, including Lorain, chronic disease, opioid addiction. We're actually going to be hiring an executive director to help coordinate efforts around opiates at the hospitals in Cuyahoga County, which I wanted to mention. Hoping to have that person hired by the end of July, start of August. And then we also do a lot of work on other behavioral health issues. So I wanted to start really at the 30,000-foot level, explaining sort of the regulatory framework for why hospitals conduct community health needs assessments. So the Affordable Care Act, also known as Obamacare, which passed in 2010, had a little provision tucked within it, which has a lot of implications for people like Martha and me, which required all hospitals to conduct community health needs assessments at least once every 3 years if they're a 501c3 or nonprofit hospital. And they have to submit all of this information to the IRS on their Form 990s. And they don't just conduct the community health needs assessment, they also, after they're done with the community health needs assessment, they put together an implementation strategy, which basically says, these are the health issues we're going to spend our time addressing because we think we're best positioned to address these particular health issues. So you can see listed here some of the goals of the CHNAs, the community health needs assessments. Hospitals need to define the community that they serve, identify the health needs of the community. They take a look at a lot of different data, and they also develop, as I mentioned, plans to address health needs. And a key focus of the community health needs assessment is really to focus on the needs of medically underserved minority and low-income populations. And then this is a newer piece of the law. They are now required to evaluate how impactful their actions are, which is great because we want to know if what we're spending our time and resources on is having the impact that we want it to have. And I will just quickly mention that hospitals take these very seriously. They can potentially lose their nonprofit tax status. So when this initially came out, there was quite a bit of panic among the hospitals, worrying that if they did one thing wrong on one line in this massive 100-page report, that they might be potentially at risk of losing their tax-exempt status. So they take these very seriously. And then I also wanted to, if that's not confusing enough, layer on top of that there's recently been some work happening at the state level, which also has an impact on the way that we do community health needs assessments and will do them moving forward. So I always think this slide is really interesting. This shows Ohio's ranking compared to the rest of the country. And as you can see, and actually it's not reflected in this slide, but they just recently released the numbers for 2016, and Ohio's dropped again down to 40th. So we have many health challenges in the state of Ohio. And we're going to continue to narrow throughout this presentation and get closer to Lakewood, which I know is what we're here to speak about. So Terry Allen from the Board of Health and Dr. Gullett also, who's affiliated with the Board of Health, and a few other people from Northeast Ohio were involved in some work at the state level, including myself, to work on the state health assessments. So the health departments also conduct health assessments that are a little bit different than what the hospitals conduct. And so the work that happened over, I'd say, about the last year and a half was to really try and get some better alignment between what's happening at the state and local level, and also work on trying to get some better alignment between what's happening with the local health departments and what's happening with the hospitals. Because right now, there are many hospitals and many health departments and many other entities, including United Ways and other entities as well that are all conducting sort of siloed health assessments. And there's really a sense that we could be more effective if we worked together. And Martha and I are spending a lot of our time working on that for Cuyahoga County. So I also will touch on transparency and accessibility and funding, which came out of this work at the state level. So this is just, I think, a nice visual which shows the work trying to get some better alignment between what's happening at the state level and at the local level, and then again between hospitals at the local level and the local health departments. So out of all of this work that happened at the state level, looking at a lot of different data sources, and then putting together the State Health Improvement Plan, these are the priority topics which the state is going to be focused on impacting: mental health and addiction, chronic disease, and maternal and infant health. And you can see here the 10 priority outcomes which they're really trying to achieve. And I think one thing that's really great about the work that has happened at the state level is that there's been a very strong focus on trying to achieve health equity by focusing on priority populations. So when we're talking about infant mortality, we're often talking about African Americans, paying particular attention to those rates because we have such a disparity there. And then in terms of decreasing suicide rates, for example, we have really high rates among middle-aged white men, so that's a priority population for that. And then when we're talking about transparency and accessibility, right now hospitals' community health needs assessments are required to be published on a public website. Typically, hospitals publish those on their websites. Not the implementation strategies, however. Some hospitals do publish those, and you can always find them because they get sent to the IRS, and there's a way to find those. But for a person in the public who's not familiar with how to access those, it can be a little bit challenging to find those. So part of this work that happened at the state level now requires all hospitals to submit their community health needs assessments as well as their implementation strategies to the state, and the state is going to be publishing those probably in the fall on a publicly available website. And in addition to the community health needs assessments and implementation strategies, which you'll be able to find there, they're also requiring hospitals to submit their Schedule H's, which will have a ton of information that the state is going to be analyzing. And there's a particular part of the information that's available on that Schedule H, which the state is most interested in. And you can see it listed here and highlighted in orange. And it's the 2 buckets of community benefit spending that cover cash and in-kind contributions and community health improvement. So you can see here, and this data is a little bit old, but for 2011, the national average for spending on those 2 buckets of community benefit was about 7.5%. And even though the years don't match, you can get a rough sense that in 2012, for the state, the average was 5%. So the state is really encouraging hospitals to be spending more of their community benefit dollars on those cash and in-kind contributions and community health improvement. And to help encourage that, we have heard that they're going to be doing some type of public reporting on this same website I was mentioning, and that they'll probably be having some type of a color coding system. So if you're at or above the national average, you would probably be marked in green, your hospital. If you're between the state and national average, you'd be marked in yellow. And then if you're under the state average, you'll be marked in red. So that's how they have, the most recent thing that we have heard them talk about. And hospitals are required to submit all of this information that I mentioned, the community health needs assessment, implementation strategy, and their Schedule H's by July 1st. Go ahead, Dan.
You can ask it.
So I'm going to move now to sharing some local level population health data, because I know that's really what you all are most interested in digging into. So I'm going to be sharing information tonight that comes from Cleveland Clinic Fairview Hospital's Community Health Needs Assessment. And I'm sure you're all very familiar with the master agreement, but this requirement came out of the master agreement between the City of Lakewood, Lakewood Hospital Association, and Cleveland Clinic. And as part of the community health needs assessment, there was a lot of analysis of many different secondary data sources, and there was also some key informant interviews which were done. And then I just listed here some statistics that I found within that community health needs assessment. 5% of patient discharges from Cleveland Clinic Fairview and 5% of discharges from Cleveland Clinic Lutheran, and then more than 500 patients discharged from main campus. So here are just some key findings which I pulled out. The uninsured rate in Lakewood is 7.4%. And you can see here the demographic trends they're projecting from 2015 to 2020. Not much change in terms of the overall population, but a slight decrease overall. And then what I think is most interesting and most important to pay attention to is the fact that the senior population is expected to increase by 20.5%. So there's going to be a need to pay particular attention to the needs of the elderly. Also, I wanted to pull out some poverty rates so you could see those. Obviously, we have big disparities here. Black poverty rates in Lakewood are at 31.3%, which are higher than the national average. They're actually lower than the county and state average, but still much higher when we look at poverty rates for whites, Asians, and Hispanics. But I think it's also important to note that the poverty rate among whites is actually higher than the county, state, and national average. And then for Hispanics, we have 18.5% poverty, which is lower than the county, state, and national average, but still higher than the rates for whites and for Asians. This is an interesting map that was in the Community Health Needs Assessment. This shows the low-income tracts, census tracts. I know that some of this data may not be surprising to some of you, but I know I was surprised by some of the green areas in the western end of Lakewood. That was a surprise to me when I was looking through this report. And I thought this was also an interesting map that was within the Community Health Needs Assessment, which shows there are 9 public schools within the city of Lakewood that qualify for Title I funding because they have 40% or more who qualify for free and reduced lunch. And you can see we have the areas of greater need at the eastern end. And I think that one in blue, I was thinking must be Harrison? Yes. Yeah. Is that Harrison? Yeah. So in terms of the information that was gleaned from the key informant interviews, which for the city of Lakewood, it looked like they interviewed people from Lakewood City Government, the fire department, North Coast Health, and also people in the schools. So I've listed here the ones at the top. It kind of goes in order of what was mentioned most frequently. So when people were interviewed, they were most concerned about access to care as a health need, chronic conditions, particularly obesity and all of the associated health concerns we have that go along with that, mental health and behavioral health services, transportation, particularly paying attention to lack of reliable transportation for the disabled, immigrants, low-income individuals as well. And then respiratory diseases, there was a lot of concern about that, particularly asthma and chronic obstructive pulmonary disease, which was attributed to smoking and secondhand smoke. And I thought it was interesting that there was mention, I have 2 boys that have asthma, and there was mention that the schools have actually had an increase in the number of kids that they need to monitor for severe asthma, so I thought that was important to pay attention to. And then obviously alcohol and substance abuse, heroin was definitely mentioned, as well as excessive drinking. And again, needs of the elderly, which are going to increase in Lakewood, according to the demographic projections. And then also, there was data in here that was an analysis of ambulatory care sensitive conditions. So ambulatory care sensitive conditions are things which we think that if we might have better access to outpatient care, we might not have as many hospitalizations. So there were actually 5 things listed, 2 of which relate to diabetes, but long-term complications with diabetes and uncontrolled diabetes, angina without procedure, which is chest pain, and then dehydration, and then chronic obstructive pulmonary disease. So these might indicate a lack of sufficient ambulatory or outpatient care or preventive care. So within the report, the analysis that they did for Lakewood, this was the summary that they put together of the key health needs based on all of the data that they looked at. And so access to affordable health care is a concern, particularly for low-income individuals and the growing elderly population. Economic development and community conditions. Cuyahoga County has really high crime rates, so that's why this made the list. and then socioeconomic concerns, and we know the areas where we have the low-income census tracts. And then in terms of chronic diseases, high rates of diabetes, smoking, and asthma, I think that was reflected in some of the earlier information which I shared. And then the high rates of preventable admissions, those are the ambulatory care sensitive conditions which I shared earlier, but we have diabetes, COPD, congestive heart failure. And then health professions education, there are actually no areas within the city of Lakewood which are considered health professional shortage areas, but just east of the city, there are primary care shortage areas as well as dental shortage areas. So that's why that also made their summary of key health needs. And that's me. My marketing team always loves to put this photo up. And we've also been blogging, so if anyone has extra time on their hands, feel free to read our blog. So hopefully I was within the time limit. And also, in closing, I just want to say thank you so much for inviting me to be here, because this is kind of like a dream for me. I never get to work in my community, and it was just thrilling to me that you all were interested in the results of the community health needs assessments. This is exactly how they are supposed to be used. And so it was just very exciting that you all were aware of them and also wanted to learn them. So thank you.
All right, we are going to open for questions. If you don't mind stating your name before you ask the question, we would appreciate it. Use the microphone.
Phyllis Jones. Maybe it's too soon to answer this question, but I know the vote was delayed today in the Senate on the health care bill, but probably something's going to go through, or maybe. How does that affect all this? Like, I noticed under federal, we were having things like, reassessments every 3 years and stuff like that. What happens to all this?
That's a great question. So currently, with the way they're trying to pass healthcare reform, the House passed version, which passed on May 4th, and then the Senate passed, or the Senate version, which they've released, and they're going to delay the vote. The mechanism which they're using to try and pass that is through the budget reconciliation process, and the community health needs assessment doesn't have any tie to the federal budget, so they cannot touch that aspect of the regulation. So that would, unless they in the future try to reform the Affordable Care Act in a different way, right now through either of those two bills, they can't reform those.
So that at least is one piece of good news.
Yeah, and yes. Janine?
The analysis you did about the health professional shortage areas, was that conducted before Neighborhood Family Practice established its site at West 117th and Lorraine, or after? And if before, do you know if NFP's presence there has changed that?
That's a great question. What's the timing on when they?
Dr. Garber, you probably know better than I do. Maybe a year and a half now?
I would have thought about probably somewhere in a year and a half.
And their newest one at the Puritas location was February 2017.
Well, they just had a new building, but they've been in that neighborhood for a couple years already.
And their newest location is, right on the border of Lakewood at West 117th and Lorraine.
That's a great question. I'll try and look into the report and see when
I'm just
they
curious,
did the analysis.
because,
yeah.
if that changes.
They have less than 2 FTE providers,
Okay.
so it would not be a large impact.
Okay.
Be a great impact. It's a lot of impact if that's where you get your care now. But community-wide, it's
I didn't realize it was so few providers.
It's less than 2 FTEs.
Hi, Laura Rodriguez Carbone. Part of your presentation talked about the community health benefit dollars. Is there any way to ascertain how much of those are being spent in Lakewood? Would that information be available online?
That is another great question, and they typically, I guess it will depend on how they are reporting that. So I think we'll know more, because a lot of the hospitals report it as a system. So my guess is that might be challenging to pull out, but I can check.
Okay.
Yeah, because there are other hospitals, different hospital systems that have part of their service area within Lakewood, and I guess that would be tricky to pull out because you'd have to pull all of the hospitals. It's a good question, though.
Hi, Kirsten. Stephen McGillicuddy. No, I'm kidding. You know who I am. So I just had two questions out of curiosity and 2 points that I think are also worth adding to the conversation. The first is to your data on Ohio has many health challenges and that we're ranked 40th in the country. I want to add to that the second half of this report of the value dashboard that you're referring to from the Health Policy Institute of Ohio actually indicates that Ohio is 47th in health value, which is both a sort of combination of where we are in terms of health outcomes, 40th, and where we are in terms of how much we pay for those, for health care and other upstream mechanisms. So we're 47th in the country in terms of health value. So I appreciate that you included this. I just wanted to add that. The second thing I wanted to lift up was the state health improvement plan, which for a fairly conservative state that they've explicitly articulated equity as an underlying value and really closing the gap between different populations and the health outcomes that they experience, I think is a really important thing for us to be considering as we empower the future board of this foundation with the tools and the frameworks to think about where they want to invest their dollars. So thank you for adding that. And then the two questions that I have, which are mostly out of ignorance and or curiosity. I'm looking at the Ohio Department of Health guidance on in the national trends in community benefit expenditures, and I see two categories. In the 2011 data, I see charity care at 24% on average and unreimbursed costs for Medicaid at 30%. And I'm trying to get a sense of what's the difference between charity care and uncompensated care. So I'm looking at the two pie charts. One says charity care, one says unreimbursed costs for Medicaid.
For Medicaid. So the charity care would be for people who do not have Medicaid. So that wouldn't encompass spending on that. So that's spending typically for folks who don't have any form of insurance. Okay. So
folks who show up to the ED who don't have insurance and
right,
primarily.
And the unreimbursed costs for Medicaid. So Medicaid doesn't reimburse fully hospitals' costs to provide care to patients. So that's they're able to include that as part of their community.
It's interesting
benefit.
that they include those as two separate measures.
So I have a chart. I actually didn't include it in here, but we've at the Center for Health Affairs we've been tracking community benefit spending. And it's interesting because if you watch the trend line, you can see that once the Affordable Care Act passed, community benefit dollars, a lot more was spent on unreimbursed costs on Medicaid and a lot less spent on that charity care amount.
Interesting.
So
the final question, then I promise to stop talking because, again, my voice is just annoying. I see in the ambulatory care sensitive conditions, dehydration is listed in the international context. When we see dehydration, usually we think malnutrition and diarrhea disorders, especially among children. What does the dehydration thing mean in the Lakewood context?
I was actually hoping that maybe some clinical folks in the room might be able to shed some light on that because that was interesting to me as well. I didn't know.
Or maybe we just have a lot of runners, like very athletic people in Lakewood.
Yeah, I did.
That wasn't my joke, by the way. That was Judy's.
I don't know. I suspect that could be a number of things. This could be young children with nausea and vomiting and diarrhea. This could be older folks sick for almost any reason, pneumonia, a urinary tract infection. I mean, almost if you're old enough and you get sick, part of what will be included in that is dehydration.
Got it. Thanks.
So very young and very old are vulnerable to dehydration.
Thank you. So, like I said, Kirsten and I had the opportunity to get together, and what you'll be able to see is we sort of took some of that data and visually depicted it in the presentation that I'm going to give that really looks at health issues, population health issues in the context of equity, and really sort of paints that picture of how does healthcare, access to healthcare sort of fit in the community context. So, we are frozen. There. So I'm going to allow everyone to just access the Cuyahoga County Board of Health website for detailed information. In essence, the most important piece of information to share is that the City of Cleveland has their own health department. Cuyahoga County serves all of Cuyahoga County except Shaker Heights, who Shaker Heights has currently their own health department. But I want to jump in because this is sort of set up to be about 30 minutes, so I'm going to be able to move through some of the earlier slides quicker. But I want to start by this quote because it sort of encapsulates the context for our conversation that, and we saw what the priority health issues were even named in Lakewood were around access to health care. And really, as a nation, over the years, we have invested a lot of time, energy, and resources into expanding healthcare coverage, improving access to care, medical care services, but yet overall health has not improved equitably or fairly across the nation. So we still see pockets of significant differences, and Kirsten had talked, for example, about infant mortality, where we see big differences in health outcomes, either based on place where somebody lives, race, ethnicity, and other factors. So I want to start by just some key terms, and some of you may have seen this depicted in so many ways. I almost feel like I actually couldn't say or describe equity till I looked at one of these types of visuals. But basically, we find ourselves gravitating to the notion of equality, that we're trying to create equality. That would be assuming that everybody is sort of starting at the same place. So the picture on the left is equality, and we see the boys of different height trying to watch the game. So if you give everybody the same box, the same size box, and they're all starting at different heights, when you give everybody the same box, all the kids can't see the baseball game. However, on the right, we need to look at what the differing needs are of particular populations. In this case, there were greater need for multiple boxes for the shortest child. So it kind of depicts the idea that it's not necessarily giving the same thing. It's meeting needs and providing opportunities for those based on folks' needs. So also there often is a lot of confusion just between health disparities and then health inequities. So health disparities are something that health departments track. Hospitals look at health disparities. Many folks look at health disparities. In essence, it's just differences in health status among segments of the population. So you could look at communities, you could look at racial groups, you could look at ethnic populations, but in essence, it's just a look at health status. Whereas health inequities are those disparities that are modifiable. So those are associated with social disadvantage and are really considered unfair. So they start to look at the communities that you live in, the opportunities that you have, the choices that you have, where you live, work, learn, and play. So gotta love the Center for Disease Control's definition for social determinants of health. But in essence, it's the conditions and opportunities that you are born into, that you grow up in, that you live in, and that you work in. But the important part of this definition that I like to call out is actually both the second and third. So it's looking at our social context, our culture in a community. It's looking at our physical environment, so the spaces that we have to be active, our opportunities to access food, health services, and even our political and societal structures sort of all play into this. And really, most importantly, it starts to look at this idea of opportunities. So based on where you live, where you work, how are resources distributed in your community or in your neighborhoods? And this is an important factor, in essence, in being able to, in essence, define or shape opportunities for people to be healthy in their neighborhoods or communities. So I kind of chunked out this presentation by a look at what is the problem, and I'll build on some of the data in the context of place that Kirsten had shared, looking both at the county as well as Lakewood. And then we'll kind of talk through why does that matter? Why is that important? And then I'll briefly talk about some of the solutions. But one of the points I always like to highlight is how important place, geography is to your opportunity to be healthy. And sometimes that can be in a really small proximity. You can live a couple of neighborhoods apart and have significant differences in health outcomes that are based on the opportunities you have, and that translates to life expectancy. So this is also a schematic that was provided by our county health rankings, which is the Robert Wood Johnson Foundation and University of Wisconsin. So in essence, there's many factors that impact health, and a lot of times we hear a lot about access to care, quality of care, even health behaviors. We talk less about social and economic factors and physical environment. And if you were to, and Dan kind of highlighted some of this around resourcing, if you look at how resources are disseminated, whether it be in our state or nationally, there's a disproportionate amount of resources, and you could tell by the percentage that was being spent on health improvement, how much is actually spent on health care, but yet we're not getting healthier. So just looking at some of the county level data. So as a county, we rank 88th among all counties, or the bottom third of all 88 counties in Ohio for residents' health outcomes. And we've been in that bottom third for quite a while. But we rank very high in clinical care. So we are consistently in the top 10. We've been 5, 6, 7. We're consistently in the top 10. Cuyahoga County is very rich in health care. And this actually looks at measured by access and quality of care, the two measures that we've been talking about. However, there continue to be significant differences in health outcomes and in life expectancy based on where folks live in the county, their race and ethnicity. And in essence, opportunities to be healthy are not fair or equitable across our county. So these are just some quick maps I wanted to show you. On the left is a life expectancy map. We've done 2 iterations as a county. And the darkest red areas, followed by the pink areas, are the lowest life expectancies. So the pink areas, in essence, the city of Cleveland and the first ring suburbs. So you can see Lakewood off to the side there in the pink area with an average life expectancy of 72 to 78. So if you even compare just Lakewood broadly to the darkest green areas of 82 years, substantial difference in life expectancy in this community. And then just looking at when you layer some of these maps visually, and you can begin to see how the data overlaps, the percent African American population and the percent poverty begin to layer on the same areas of the county. And then you will be able to start to see some of those patterns for Lakewood. And I think this is an important conversation to begin to look at, you know, when you, even in a small community like this, you know, where are the opportunity differences to be healthy? Where are the differences in health outcomes? And perhaps what in the community is fostering those differences in opportunities. So if you look at just this population map, I just highlighted again here the African American population and other races where the highest concentration of those populations are in the city. And this is just, again, just to remind you, this is the map that Kirsten had shared, just again, visually remembering where those low-income areas were. Well, this is just looking at the poverty rate. So the larger map is contextually looking at where poverty is concentrated in the county, and then where is it concentrated in the city of Lakewood. So here, the darker the color, the higher the poverty rate. So again, concentrated in those areas in the red circles, and you will start to see some consistency in pattern looking at this information. So this is life expectancy, and the lowest life expectancies are the lightest colors on these maps. So the very light green, just for point of clarification, the white areas does not mean even lower. It's an area where we didn't have a concentration of population that could adequately allow us to do the calculation. So that does take out that one area where we had seen concentration of poverty. But you do see that the lightest colors are concentrated in that 1617 census tract. And this is just another example. These are lead levels. I was telling Kirsten this is sort of an unusual pocket for me here up in the other upper left-hand corner there. And these are blood lead levels compared to national averages. So The darker the area, the higher, basically the darkest color is 3 times the national rate for blood lead levels. So really the reason to talk about this is the idea that we really need to begin to think about how opportunities differ just across the community, and how do these health issues play out in the community context and in the opportunities that are provided. So not only is that unfair and unjust, thinking about a community having different opportunities, especially within one municipality, not across municipalities, but in one municipality, but there's considerations for economic costs for a community to think about, and where are investments made and what is the return on investment. Because there's one line we use a lot in public health is, 2 of them, we all pay for poor health and we all do better when we all do better. So, you know, the idea is that if we invest in the areas of greatest need, if we invest in areas where opportunities are not the same, and we elevate that population and they have healthier lives, then we all do better. So economically, we all do better if they're not drawing on the healthcare system. So this is just a visual schematic that is sort of a compelling equation to sort of keep in mind. This idea that unequal opportunities where you live, work, and play, coupled with poor health, which is a consequence of unequal opportunity, results in shorter lives. So a couple of other ways to look at this. So in public health, interestingly, we have been pretty disease-centric for a long time. It has only been recently that we have sort of evolved to a better understanding. And we have spent a lot of time in this space here thinking about and understanding the causes of death around disease states. So we heard a lot about these disease states in the community health assessment data. And public health has made a smoother transition to looking at behavior change. So, you know, tobacco rates, we know tobacco, you know, is a significant factor in chronic disease. Poor diet and physical activity. We have talked about these traditional public health factors that impact health. What we have talked less about and understood less is really what is at the root of these actual causes of death and then the causes of death. Really recognizing that the opportunities we have, like education, issues around segregation, poverty, these social and environmental factors are really having a much more significant impact on long-term health outcomes. So we have used this framework a lot to sort of talk about this. If you look on the red border, medical model, I don't know if it's your right or my left, but the medical model is sort of that traditional public health environment where you see mortality, disease and injury, risk factors, and behaviors. This is the space that public health and healthcare operate in. This is what you could equate with an understanding of how we recognize health disparities. We have used the terminology upstream a fair amount in our conversations and referencing work to address population health. Upstream work begins to look at community conditions, social inequities, neighborhood conditions, residential segregation, workplace conditions. And then institutional power you can think of is who's making the decisions about what opportunities are available in our communities and neighborhoods. Corporate and other businesses, government agencies, schools. These become those institutions, those systems and structures that we need to begin to think about as we think about healthcare more broadly. And then discriminatory beliefs are those social factors that you just saw on the previous slide that really influence how decisions and what decisions are made. These are value-based decisions that are often very powerful and ingrained in how policy decisions are made. So race, class, gender, immigration, national origin, et cetera, are those social factors that in essence shape health inequities. So this is a really great way to sort of thinking about that context of traditional public health and now upstream, more health equity focused public health. So a little bit about solutions. So in this context, this is a complex environment. So as you saw, as we talked about the ecological model or upstream frame, you're starting to talk about neighborhood conditions, institutions, systems. It creates a different level of complexity that starts to cross multiple sectors. It's no longer a healthcare or public health by itself issue, and it starts to require us to bridge relationships with non-health organizations and thinking about ways that we can work across sectors collectively to address some of these issues. So I just highlight this because for public health, really this is our most important role. How do we ensure that all people, regardless of race, ethnicity, where they live, where they work, how can we ensure that all people have the opportunity to achieve their fullest health potential? So diving into solutions, this is actually a really good representation of how to think of it as a whole. And this is actually the County Health Rankings, Robert Wood Johnson Foundation Action Cycle. This is a great website to actually access information on process, on policy, on evidence-based programming, et cetera. And in essence, it highlights the need to work together, to communicate consistently and transparently. And it moves through, in essence, the process that we've started to think through as a partnership, looking at the needs and resources available in this community, focusing on what's important, what are the important issues, what are the gaps, and then choosing effective policies and programs. And I highlight that because it's policies and programs. We have to think across that continuum, not just from a program perspective for long-term impact. And then acting on what's important and ensuring that we're evaluating our efforts. I also like to share this because from a public health perspective, you would imagine that public health is focused on evidence-based only. We have found that to address some of the complex issues that we're experiencing, evidence is not the only way that we can proceed. We have to be open to innovation and really engaging with the community in a way that informs our work. So in essence, yes, we look at best available research and evidence, but we also look at population characteristics, needs and values and preferences. So we need to engage with the community, understand what that community culture is and what that community's values are. And yes, we will also engage experts. And then it's also taking all of that in the context of the community, the environment that we're actually operating in. So just wanted to share, and really these are not things we have to spend a lot of time on, but there are some wonderful resources on Health Policy Institute Ohio's website that talk about policy, system, and environmental change and begin to define those terms and offer very user-friendly ways to think about policy change. But in essence, the most important piece is that we really need to think about changing laws to shape communities in a way that provides opportunities for health, especially for populations that are typically underserved or under-resourced. And it's worth mentioning, too, when you think about policy, that there are sort of two big buckets of policy. Big P policy, we describe as formal laws, rules, regulations enacted by elected officials. So these are transportation policies, maybe housing policies, budget policies, very large policies. Small P policies are also important because these can be some of those organizational level or institutional level policies that shape how your organization does business. So if you want to have an institution or organization that is more responsive to, for example, a focus on equity, there are things that you will need to put in place as an organization, from your structure to how you strategically think about your work, how you set up your infrastructure, all have to be considered, and those are considered small P policies. So from a solutions perspective, there are some resources that begin to highlight evidence-based or promising practices that can be considered. So this is actually the Health Impact in 5 Years resource from the Center for Disease Control. And if you think about sort of the upstream, downstream context we've talked about, social determinants of health are called out at the bottom of this pyramid, emphasizing the need to really think about focusing in those areas because there are long-term change opportunities. and not as long as maybe we would have thought. This is highlighting the fact that you can see impact in 5 years. And right above that is changing the context, the idea of making the healthy choice the easy choice. So you can see in each of those boxes some of the strategies that the Center for Disease Control provides as opportunities to explore, and certainly there would be a need to understand how some of these apply to this community as we move forward through this thinking. But this, again, is also accessible as a resource as we begin to think about what priorities may be and what potential solutions we could consider. Then I also want to share another resource that connects to the State Health Improvement Plan. The Health Policy Institute of Ohio was instrumental in guiding the work of the Health Improvement Plan for the state. And they actually put together a resource, Evidence-Informed Strategies to Reduce Health Disparities and Inequities. This is accessible on the Health Policy HPIO.org. You can access this and other materials similar to this on their website, and again, can be very informative. And also the County Health Rankings website also has evidence-based resources. So what they actually do is they rate, in essence, the policy or program opportunity, whether it's evidence-based, if it's evidence-informed, is it innovative or what have you, so that you can be informed in how much support there is or evidence there is for that particular priority. So I just want to spend a minute on this, collective impact, because it's come up in this room several times. For public health, it is an approach that public health supports, from the notion of that to address complex issues that we're talking about, there needs to be an understanding and a philosophy to work together for the greatest return on investment. Bringing different sectors together brings different knowledge base, different capacities, different resources together. And if you harness that collective power and that collective understanding, knowledge, especially resources, around a shared set of priorities, the opportunity to have a greater return on investment is much higher. So there are some simple principles to collective impact that are just worth understanding. And if you look at the comparisons between collective impact, coordinated impact, individual impact, you will see that oftentimes we're working in this coordinated impact, where there's a lot of people working on the same type of thing. We're all working in healthy eating, active living. We're all sort of but it's not coordinated in a way so the resources are dispersed, and it's not funneled in a way that really maximizes resources and collective capacity. So we're really trying to get a set of folks to begin to identify priorities and really work in full alignment around a shared agenda. So again, I won't repeat these, but common agenda, shared measurement, talking about what are the ways that we will collectively decide to measure our success or progress. Mutually reinforcing activities, continuous communication that's transparent, and this idea of backbone support is one or more organizations that coordinate the work, don't lead the work, but coordinate the work of the collective. So if you're looking for resources on collective impact, there is a website, fsg.org, or the Collective Impact Forum is an opportunity for you to sort of learn more about these principles. But this was a nice slide from FSG that began to show some comparisons of how we normally think about addressing health or population health. We usually think at a very individual program sort of approach, and usually a very short-term approach to addressing health issues. This is not a one way to sustain and have transformational change or a long-standing population health change. Again, really looking at the interaction of many organizations aligned around a set of priorities, really operating in a larger system. Also, shared goals and measuring the same things. So how many times have we worked with organizations where they're all working in healthy food and they're all measuring it in a different way? We can't garner outcomes from that because it's being collected and measured in so many different ways. So coming up with a dashboard of those measures that we all agree on. And then evaluation measures also need to change. We're not measuring how many people participated in the education program. We're trying to understand, how did the system change? How did opportunities in Lakewood change, for example? You know, how has population health improved? And also, this idea of alignment and continual learning and embracing the opportunity for innovation is also critical. And again, all partners are essential in this concept. So lastly, this is another example of sort of this continuum of collective impact and how it differs from other collaborative approaches, starting from the bottom. Social, and we've all heard these if we've worked in our networks, social sector networks, multi-stakeholder initiatives. It's probably the most famous and long-standing. Public-private partnerships, funder collaboratives. These all differ from collective impact distinctly because of its long-term orientation, long-term commitment of a set of partners around a shared vision, a shared set of values, a shared agenda. So I don't put this out there as something that this, you know, our task force would say must be something that we support, but this is a recommendation that could be made you know, as we think about how resources might be used in the future as a strategy for especially a community of this size. The value of alignment and coordination could really maximize resources and maximize impact. Thank you.
That was so informative. I'd like to be able to look at it again.
Oh, absolutely.
A couple times. Can you either send it to us or put it up on the...
For sure. So it's going to be publicly available, but I was finishing it in the last memento, so I can definitely email it, and then Shannon can send it out.
Thank you.
I have a question. I'm a big fan of collective impact. I'm just curious to know, from where you sit, how successful have we been as a county with collective impact?
So I've got a few colleagues here working on it. You know, I will always say it's a work in progress, and if you look at any collective impact initiative across the country, the challenges are the same. But I will highlight the successes. So just for example, for the health improvement planning process that we've embarked on, we started in 2009. You know, our partnership has grown tremendously from an original set of 50 partners to well over 100 active organizations. The network has grown from 200 in the network to over 900 in the network that we communicate with. I think we commit to ongoing capacity building and discussion around the topic. So I think it's a work in progress, but we have really retained a core set of partners for quite a long time, and we've actually added others. And we have a diverse steering committee for that process. We have community residents as part of that process. So as you can imagine, there's growing pains of all kinds of orienting community members to the process, new members, but overall, we feel good about that framework for the work, and we feel good about the commitment to that work. I will say probably the greatest challenge that we've experienced is folks balancing the responsibilities to their organization to the responsibilities that really are necessary to really bring that group together in the way that they need to synergize. That's the greatest challenge. And I don't know, Dan, I don't know if you have any other insights as a member.
I serve on the HIPSI steering committee and on the steering committee of Healthy Cleveland, which is another pseudo-collective impact model. And the only thing I would add to that is I think sometimes it can be challenging to be laser focused in moving initiatives forward when there are so many people in the conversation, and that's sort of the fun of the challenge, but the challenge of the challenge is coming to consensus in that collective impact model about how to move things forward. And I think the process in and of itself invites conversation about to what extent can we make decisions and move things forward in an effective and an efficient way and to what extent do we need to really kind of slow down and wait to have more input. And I think that that's something that HIPC is working on, Healthy Cleveland is working on, a lot of collective impact folks are working on.